All right. Hello, everyone, and welcome to today's Tidy Products sponsored webcast event. My name is Katie Malooly, and I am the Marketing Communications Manager. We are honored to bring to you today's presentation, CMS Hospital Restraint and Seclusion, Navigating the Most Problematic CMS Standards and Proposed Changes. During this program, we will discuss the most problematic standards in the restraint section, as well as the proposed changes to restraint guidelines in the Hospital Improvement Act. This program qualifies you for 1 credit hour. If you are watching the presentation with a group of your associates and only one person is registered, simply email their first and last names along with their email addresses to the email address that was on the screen, cmalooly@tidyproducts.com. That's C as in cat, MALOOLY @tidyproducts.com. Each person will receive a webinar survey where the option to receive the credit is available. You will receive the certificate 1 week after completing the survey. We will save all questions until the end, and they will be answered in the order they are received. You can submit your questions in the chat panel on the Q&A box located on the right-hand side of your screen. Today's event is being presented by Sue Dill-Calloway. Sue is a nurse attorney, a medical legal consultant, and the past chief learning officer for the Emergency Medicine Patient Safety Foundation. She is the immediate past director of the Hospital Patient Safety and Risk Management for the Doctors Company. She is currently president of Patient Safety and Healthcare Education and Consulting. She was a medical malpractice defense attorney for many years and a past director of risk management for the Ohio Hospital Association. She was in-house legal counsel for a hospital in addition to being the privacy officer and compliance officer. She has done many educational programs for nurses, physicians, and other healthcare providers. She has authored over 102 books and numerous articles. She's a frequent speaker and is well known across the country in the area of healthcare law, risk management, and patient safety. She has taught many educational programs and written many articles on compliance with the CMS and Joint Commission restraint standards. It is now my pleasure to turn the webcast over to Sue Dill-Calloway.
Why, thank you, Katie, and welcome everybody to this 2-hour program where we're going to go through the CMS Hospital Restraint and Seclusion Standards. And they just came out with the new deficiency report. And so this is a timely program. There were 2,917 hospitals that have received a deficiency since CMS first started publishing the results in March of 2013, which is a huge number. And it's also timely because we're going to talk about a proposed change in the restraint standards by CMS. So this is a really hot issue. And so we're going to cover what it is that you need to know to help prevent this, and we need to share the word. And I would like to thank Katie for being our moderator, and Beth Hudson, who's been my contact person. And she was we were just chatting right before the program, and there were 570 hospitals that had signed up for the program today. Now on slide number, and so we may not have time to get to all of your questions, since that's just locations. And some, I know I was talking to someone yesterday and they said, oh yeah, we're going to have 35 people in the room. So there are a lot of you out there, but I always give you my phone number and you can call me if you have a question. And also it's the 614-791-1468. But also, I don't accept email questions because sometimes I don't get them or I don't understand them. But if you call me, I'm happy to help you. I have office hours from Monday through Thursday, 10 a.m. to 10 p.m. Eastern Time. And today I'll be working in the office until 11 o'clock. So if you have a question, you can feel free to call me even if it's late, and I will help answer your question. Sorry, we just have the slides that are moving a little slow today. So let me go back. We don't want you to get one of these. This is a bad thing. There are 50 pages of restraint requirements out of the 542. So anytime you see, 10% of a manual, in one area, you know that it's important. But if CMS, the Centers for Medicare and Medicaid Services, If they find out that you're not in compliance with these 50 pages, this is what they'll send you, and this is a bad thing to get in the mail. And these are headlines that you don't want to see. And I know in our behavioral health unit, we used to call it a code brown if somebody was acting out. And the only people who were ever allowed to go in the room were individuals, and CMS mentioned CPI by name, but there are other companies that are out there doing similar things. But you had to have the 8-hour course, and only those individuals were allowed to go in the room, because if you have to do a takedown, you want to do a safe takedown. And otherwise, and especially you'll see where there's a lot of deaths related to the prone position. And I'm just having a little problem with my slides not wanting to move very fast. Here's a hospital that not only will CMS come out, and CMS can also turn it into a validation survey. There are two types of validation surveys. And by the way, the second one is going to be changed this year, where 150 hospitals just get selected. And this time, if the accreditation organization comes out, you may see CMS coming out with them. Okay, just having a little trouble getting slides to move. Katie, I'm having trouble getting the slides to move. Can we do you know how to do a share my screen?
Let me see what I can do. 1 second.
And while she's doing that, I'll talk. So this is an example of the prone position, which is the more dangerous one if you have to do a safe takedown. Okay, cool. There you go. So Katie, are you seeing my screen right now?
Mm-hmm.
Okay, cool. Okay, great. Yeah, I was hitting it and it was taking like 30 seconds. And
sorry about that.
Yeah, computers, you gotta love them, but sometimes they drive us crazy. This will be really fast. Cool. Okay, now we're really ready to rock and roll. Okay, so anyway, this is an article that actually this was in many articles. And what happens is every hospital that accepts Medicare and Medicaid has to follow the CMS requirements. And if you don't, and CMS finds out and they come in, they can actually take your reimbursement away. So this happened in March of 2017. And this was a 48-year-old patient who came in and was strapped to a gurney. And what happened is he had been shot in the arm, and the security officers had struggled with him. And what they did was they when they put him on they put him face down again, which is a dangerous position to do that. And he actually died. But not only did CMS come in and threaten to take away their Medicare and Medicaid, this was a double whammy, because when the coroner did an autopsy, he said it was a homicide. So if this was a homicide, then who killed him? The security guards. And not only, is this hospital facing a wrongful death, but also criminal charges against their security. This is more if you want to read about it. And this was an article I liked because I always say this: rethinking restraints in hospitals. When I got out of nursing school in 1975, we used to restrain everybody and their brother. And if somebody fell, the first thing I would do is put the call light on, and the ward clerk or the nurse aide would bring back 2 soft wrist restraints, and we would restrain everybody. If you automatically do that today, just like we used to do back then, that's going to get you into trouble, because some patients may need it and some may not. So where it used to be a first response, now it's, is there anything we can do besides doing that? So that's kind of why I like the title of this article. And also, we also went to benchmark and, monitor what our data is. And I mention that because sometimes hospitals are using old studies and thinking they're doing, really, really good when, maybe they're not so good. So this was a study that came out in 2007. And so it said about 5 restraints every day in the hospital, and the prevalence is about 50 per 1,000 bed days. But what I want to advocate to you is that we have gotten better. There are other products that are safer, other things that are doing it with low beds and mats and all kinds of stuff. And then they also mention an older study that was in the Journal of the American Medical Association, which is still true, that restraints does increase the risk for delirium, and they can increase pressure ulcers or respiratory complications. And in fact, most hospitals don't use the best restraints anymore because those were the ones that were more associated with, strangulation and some problems. And then they mentioned the 2006 study, which is actually what's going to lead us into what we're going to talk about in just a second, in that 40% of hospitals, when somebody died in a restraint, never reported it to CMS. And that's why CMS created a reporting log, a reporting form, which I'm going to walk you through and show you how to fill it out. And that is actually why why they have made some changes. And a couple years ago, they tweaked that, which is really important. And I was looking at their form last night, and they still don't have that particular change in, but we'll talk about it in just a second. So this is the article if you want to go and read it. And then we know, this is one of many articles that are out there, that if you have an adequate number of IRNs, that you're probably not going to be using them as much, and you're only going to be using them when they're actually necessary to protect the staff or the patient. And they talk about how restraints can lead to agitation, confusion, and adverse psychological effects. And I was an adjunct professor for the College of Nursing for 17 years, and I used to teach this part. And, I used to make the students, to, instead of just, and for competency, you want to observe your staff putting on, for example, your soft wrist restraint. But in the lab, they had to put on 2 soft wrist restraints, and they had to, and of course, we had the beds down there, and they actually had to stay in the restraint for 10 minutes. And I remember one student, after about 3 minutes, was so agitated and like, "Get me out of these." She said, "I'm never going to put these on a patient." And I'm like, unless it's necessary. And I'm like, yeah, okay, you get it, why, we need to use them, but we want to make sure that they're used appropriately. And so this is a good article if you want to read it. And this is just what I was talking about earlier. This is data from the National Data Bank of Nursing Quality Indicators. And data between 2006 and 2010, they found that 1.6% of patients were restrained and 51% were restrained to prevent from falling. But during this 4-year study, the use of restraints dropped 50%. And again, the more RNs, the lower the use of restraints, and they can actually calculate it out that if you had a shortage, and if you had a shortage of nurses and you substituted it with, for example, nursing assistants or LPNs, it should increase the number of unnecessary restraints. And the author said that RNs are better trained to find alternatives to restraint and seclusion. And so, again, belts and mitts, we'll talk about mitts. Again, most hospitals don't use vest restraints anymore. Bed rails, geriatric chairs, other devices. And so let's talk about the CMS. Now, most of the people call the manual, which I'm going to show you how to get to, the COP manual for short, or the COPS, the conditions of participation. In fact, I was reading an article yesterday, and they were talking about the COPS, and I'm like, what is this, and here they were talking about the police, and of course, the first thing I think of is the COPS, is that 524-page manual that we as hospitals have to follow, in most hospitals except Medicare, so we have to follow it for all patients. And the manual is also known as the State Operation Manual. Don't be confused. It is the same thing. And the manual has tag numbers or sections, and the regular numbers go from 1 to 1,600. And they recently added the swing beds. There are some small rural hospitals, so tag 1500 to 1576 are swing beds. But the restraint standards go from tag 154 to tag 214. And as we're walking you through this presentation, you will see the corresponding tag number. So if you say, and I'm going to show you how to get the manual for free. So if you say, you know something, I want to look up tag 154, it's kind of a problematic standard, you will be able to do that. Now, one wonderfully important thing is that CMS now has an email address that you can email questions to. And I've used this about 35 times. And I noticed that 30% of all the questions that I ask CMS happen to be related to restraint, because I can tell you what they do say, but I can also tell you what they don't say. And sometimes it's just really nice to have it in writing in case the state agency, you know, the regional office sends the state agency, the Department of Health or whoever out, and to say, well, you know, why did you do that? Well, I got it in writing from the central office, and here it is. So this is really dandy. Here is your email to ask any questions and get them in writing. They have assured me multiple times that they will never come and investigate you because of a question that you have asked. They put that in writing multiple times, and indeed, I've never heard of, you know, anyone ever, you know, finding that not to be true. And how it ends up into the manual is that first they publish things in the Federal Register. When the regulations are final, then they come and add interpretive guidelines. And some of them, but not all of them, have a survey procedure. And I'm going to tell you how to keep current, because I always get asked that question. Okay, you just said that there are going to be some proposed changes, and we're most likely to see them in the next 5 months. So how will I know if and when those are are promulgated? So I'm going to show you, have one person who, or two people who once a month go out and check to see if there's a new manual, check to see if there are any survey memos, and sign up to get the Federal Register. And I'm going to show you how to do that free. So on slide 17, here's your email address, and here's the web address. And if you go out, this will take you to all the manuals. So today we're talking about Appendix A. All you have to do is hold your browser over the letter A, and up will pop the manual, and it will always bring you to the most current one. And you will notice that it says at the top of it, State Operation Manual. Again, most of us call it the COP manual. And when they implement those new regulations under the Hospital Improvement Rule, again, if and when they do that, they will most likely issue a survey memo. So on slide 19, this is your survey memo. You just click on whatever one that you want. For example, if you wanted to see the 13-page memo on suicide patients and how to prevent them from committing suicide, you would just click where it says clarification and ligature risk. Or if you wanted the survey memo that you're never allowed to text in an order on the third one down, you just click on it and up it will pop. And this is what the survey memos look like. They pretty much all look alike. And this was a memo that CMS sent out because they take, there's 10 regional offices. So they've divided all the states into 10 regional offices. And the regional offices are supposed to communicate with the hospitals in that area. Okay, so can I fax in this report that I'm going to show you? And then do I need to call and leave it on a, voicemail line, or what do I need to do? And then whenever they create a survey memo, they reserve the right to tinker with it. And when they get it into the format that they like, then they will issue a transmittal. This is the website to sign up to get the Federal Register. It comes to your computer every day. And you just kind of go to CMS or OSHA or whatever you're looking at. It takes a second. And this is a resource that is available. That is a Word document. I've actually updated it. And then I recently did one, and Dr. Boudreau gave me permission to share this particular one. So we will be happy to do that. Now, how did I know that there were 2,917 deficiencies? How did I know that in the entire CMS manual that patient rights, which are over 8,000 deficiencies, and again, we have almost a third of them being restraint and seclusion. So how did I know that? So in March of 2013, for the first time, CMS started issuing deficiency data. And that's how we knew that restraint was one of the biggest problems facing hospitals. And again, if you know that there's a little less than 4,000 acute care hospitals under Appendix A, and I'm telling you that, 75% have received a deficiency, that kind of puts this problem into perspective. This has, and by the way, we normally update the data every other time, and they hadn't actually. There were over 6 months last year where they didn't actually do any deficiencies. So I was really happy 2 days ago when they updated the report. So, but one of the things that we found out is that the problematic standards continue to be the problematic standards now that we've had, 5 years of data. So these are all the tag numbers, and you can tell which ones are the problematic children, and we're going to cover every one of these today. And again, so from April of last year to the new report that came out a couple of days ago, we are now at 2,917. So that means that we've had 400 hospitals that were cited since that report. So I guess what I'm advocating is not only is it a problematic standard, but we are seeing a lot of hospitals get cited. Also, there's another report called, if you go to hospitalinspections.org, you can also read. In fact, the other day, I spent a few hours reading why every hospital had been cited for restraint and seclusion in the last 2 years, and it's quite helpful to understand that. So anyway, let's talk about terminology. First of all, if you are accredited by one of the 4 accreditation organizations, for example, and the Joint Commission accredits about 90% of the hospitals. And in fact, just a few months ago, CMS gave us the data. They actually said there were 3,460 hospitals that were accredited by an organization, 3,035 by the Joint Commission, 264 by DNVGL Healthcare, the Healthcare Facility Accreditation Program, 122, and CIHQ 39. But what I'm going to advocate to you is that you also want to be aware of your accreditation standards if you're accredited by one of these 4 organizations. And indeed, for those hospitals, the 264 hospitals that were accredited by DNVGL, this month they came out and said, if you have a violent self-destructive patient and you have to put restraints, that you need to get an order immediately. And then in parentheses, they put within a few minutes. So it's helpful to know that. And then always be aware also of any specific state law that you have. In most states, if you have, for example, I worked at a hospital and we had a dedicated behavioral health unit, and they will often have requirements. So while CMS doesn't talk about debriefing or de-escalation, most of your state laws will require that for behavioral health patients, especially if they're in a behavioral health designated unit. Now, as far as terminology, for example, since Joint Commission accredits about 90% of the hospitals, they use different terminology. They say the patient is either behavioral health or non-behavioral health, but CMS uses the terminology that the patient is either violent and or self-destructive, or they're not violent, non-self-destructive. But what CMS is saying is it's not the department that affects the standards, it's the behavior. So I could have a patient who is violent and self-destructive in the behavioral health unit, but I could also equally have one in the emergency department. And so when I was at the hospital one time, and I had to write our policy on restraint and seclusion, I wrote one policy that had three parts. Now, one of the things I found when I've gone into work with hospitals is they'll have multiple policies and they don't link them together and they're not in one place. So if you are going to separate them out, make sure you say, okay, restraint and seclusion policies are also located in the following three policies, so people will know to go look there. So what I did was, since we had a behavioral health unit and since our state had specific state laws on behavioral health units, I said, okay, policy A or policy 1 is only if you are in the behavioral health unit. And then policy B is if you are anywhere in the hospital outside the behavioral health unit and the patient is either violent and or self-destructive. And then I put in parentheses, because we were Joint Commission accredited, behavioral health. And then the third one was if the patient is not violent, not self-destructive. In other words, in parentheses, I put, non-behavioral health. So the terminology, don't be confused by that. And again, it doesn't matter who you're accredited by, you still must follow the CMS requirements. And by the way, these four organizations have to apply for deemed status, meaning they have to assure to CMS that their standards meet or exceed it. So I'm also advocating to you, to the 570 hospitals that signed up, that this will help you if you are accredited by any of these organizations. And then I also wanted to remind you that CMS does have a complaint manual, and it tells surveyors how to investigate complaints. And they updated it in 2016, but anyone can get access to that. So normally we suggest that you have one restraint guru who's responsible, and that person should be, looking at this and incorporating what it says in the policy, because it talks about what it is that they're going to do. The other thing about this important memo is that often when there was an accreditation organization and CMS came in and found a deficiency, they didn't always communicate it with that organization, and now they are doing that more. So there could be a second knock at your door. So what about the proposed change? So what CMS says now is that you have to, if you're going to order restraints, it has to be a physician or a licensed independent practitioner. Of course, you credential and privilege them to do that. And I noticed there were some deficiencies where hospitals were letting, for example, a nurse practitioner order them who was not credentialed and privileged to do that. So anyway, you want to make sure that it is a physician or an LIP. So what is an LIP, a licensed independent practitioner? Well, CMS doesn't tell you who in your state is an LIP. Your state does. And they're just going to follow whatever your state does. So in my state, for example, in most states, nurse practitioners are LIPs, licensed independent practitioners. But in some states, including my state, our state medical board has determined that our PAs are dependent practitioners because they can't just admit patients to the hospital. They have to work under the supervision. And so what happens is if CMS changes, and this is what they want to do, the term from LIP to LP, licensed practitioner, then we don't ever have to worry, and that, any hospital that wants to, after this passes, could allow a PA to do the same things that a nurse practitioner. And I know even though I've always had a full-time legal and risk management job in patient safety, I used to work until about 6 years ago, 2 or 3 shifts a week. In the last hospital, I worked 20 years in the emergency department. And we always had 2 physicians and 1 either nurse practitioner or PA, and their practice was indistinguishable, except the PA couldn't order restraints, which was kind of silly. So anyway, this would take care of that. So again, this is proposed. Now, this is, I'm just going to call it the proposed hospital improvement rule. And the full name is a long name: Medicare and Medicaid Program, Hospital and Critical Access Hospital Changes to Promote Innovation, Flexibility, and Improvement in Patient Care Proposed Rule. That's a mouthful. If they are going to promulgate this, and I've called them multiple times, and all they say is, if and when, look in the Federal Register, but it's still on our work plan. So if they're going to pass this law, it must be passed because under the federal law, they only have 3 years to do that. So if they are going to promulgate this, it must be promulgated before June the 16th of 2019. So we should see something in the next 5 months if indeed they are going to move forward. Now, there's another significant proposed one, the hospital discharge planning rules, and they kind of threw us for a loop in November the 2nd of last year when they were given a year extension, but usually they just have the 3 years. So unless they try to go for an extension, we should see this in 5 months. So as I mentioned, we're talking about Appendix A. I showed you how to get it. Just click on the A, and up will bring up the COP manual if you want to look up any of the tag numbers we are going to talk about. And also, if you are a critical access hospital, we have some hospitals that are in systems with beds, hospitals that they usually have to be 35 miles away from the next hospital unless there's mountainous terrain or secondary roads, and they're normally 25 beds or less. They can have up to a 10-bed behavioral health or a 10-bed rehab unit. If so, they're governed under Appendix A, and I know that is kind of confusing. That's just how they do it. Except in the swing bed regulation, they do have restraint and seclusions, which, by the way, they just rewrote all of the critical access hospital swing bed regulations October the 12th of 2018, so just a few months ago. But the bottom line is that critical access hospitals have to do something. So most critical access hospitals will adopt most of these same standards. And because we are seeing a lot of critical access hospitals go into systems, that we're seeing them just adopt, the hospital's policy in the system, which your board must specifically do. So again, here's the website. Again, just click on A, and the tag number will always be at the top left-hand side. So if you have a question, and I gave you the email address 3 times now, you can email CMS. You would want to say, I have a question about tag number A154. You don't have to say the -O. You can if you want, but you need to have the letter A. That way the surveyor knows that you're a hospital and they know what manual you're talking about. Now, the other nice thing is that at the top of each one, they tell you when that section was last amended. So tag 154 hasn't been amended for 11 years. And whenever I write a policy, I will always put down at the bottom, this policy is written to comply with CMS conditions of participation, tag 154. And that way, if I'm gone next year and somebody else is looking at it, they can say, oh, well, this hasn't changed in 11 years. It's probably current. And that's going to be helpful. Also, we'll talk about having one person every year, the requirement to keep it up to date. And I would actually cite the articles on which our policies were based. And CMS wants us to do that because they have been because when you're doing evidence-based, and you'll see that a lot in the last 3 years. And by the way, I noticed in the chat box that there have been a lot of questions about, are the slides available? And the answer to that is yes, the slides will be available. In fact, they have been posted, added to the handout section of the webinar, which you can just go and download them. If you look at handout and you just click on that, you can send it to yourself or download it or whatever that you want. And also, the presentation is being recorded for future access. Now, the worksheet. The worksheet is mandatory now, and I'm going to talk about, and so remember I mentioned there are 10 regional offices, and this is a list of the regional offices if you're not sure who is your regional office, which has their phone numbers and fax numbers and everything. But it still says that that we need to notify them by phone the next business day, which is why CMS sent the memo and said, okay, regional offices, let the hospitals know how you want to do it. So In my area, we fax it in and we leave it on a voicemail to make sure that they know that we have gotten sent the information in. And so right now, so basically you have to report to CMS on the form. So, but they made an exception a few years ago. It used to be that you had to fill this form out and not send it to your state agency, but your regional office if the patient died in a restraint, if they died within 24 hours of being in a restraint, even if the restraint didn't cause the injury, it's just a simple reporting one. And if they died within 7 days and the restraint caused the death, then you had to report. A few years ago, they made one exception, which was a big exception and applauded by hospitals. If the patient dies and all they have on is 1 or 2 soft wrist restraints that did not cause the death, so this was a trauma patient, had brain injury. We were pretty sure when the patient came in, he or she was going to die, and they did die a couple hours later. They were in restraints for 2 hours in the emergency department. Then we don't have to report it to CMS on the restraint log, but we do need to have an internal log where we document that. And in the chart, I'm going to say this has been documented in the CMS internal restraint log as required. So that's what you want to do. And this is the website for the form. Actually, it's all white now, but it's the same form. So you put in the hospital name and address and provider number, CCN number, the person filling it out, and whoever is completing this, their phone number. Also the patient's name and date of birth, medical record number, date of admission, date of death, and then cause of death. And then on the bottom, you mark, did they die? And generally, as a practical matter, they're only going to come out in most cases if the restraint caused or contributed to the death. And look at the 13 things. So you could mark side rails, and we're going to talk about when is a side rail a restraint and when is it not. If they had 2-point soft wrist restraints, 2-point hard wrist restraints, 4-point soft, 4-point hard. And you notice that there's nothing in there about leather, the real leather, primarily because the infection preventionists told us not to use them anymore because there's no way to clean them. Now, they make a fax leather, which can be cleaned. Forced medication hold. So if this patient is going berserk and I get an order for medication and I have to hold them down, then I get an order for the forced medication hold. Therapeutic hold. So, and it used to be, Joint Commission used to allow a timeout holding down a child under 18 for 30 minutes. But that's no longer true. If you do that, you have to get an order. So if there's a session and, one child is going to, jump up and it's going to hit the other one and we have to hold them down to prevent them from doing that, then we're going to get an order. And again, a takedown. And again, you only want people, and we'll talk later on because CMS says your security, which are usually the ones doing it, should have 8-hour class like CPI training. Again, they mentioned them by name, but there are other companies that are doing that. And you want to be careful about the prone position, the face down, because we know that results in a lot of deaths, and you want to be very careful about that. And if your police are doing it, you're still responsible as a patient, and you need to monitor them. We had a hospital in our state where the police did a takedown, and, quote, hog-tied them on a backboard, and the patient died, and, of course, the hospital was responsible. Enclosure beds, we'll talk about that. Again, most vest restraints are not being used. And elbow immobilizers, if you put 2 of them on and they can't remove them, then they are considered a restraint. And I'm not really sure why 13 is on here because CMS says that forensic restraints or law enforcement restraints are not a restraint for purposes of CMS. Now, not that I don't evaluate those and pull out the sheet and say, oh, I'm using these to monitor them. And then we'll talk about when a drug is a restraint and when it is not a restraint. And so this is the form. So again, we have about 50 pages of restraint and seclusion standards, and we just talked about the reporting requirements. So let's just jump in. Now, if you've ever sat down and tried to read the 50 pages of restraint standards, they're not organized very well, and sometimes they're hard to read. And I think that's why we have almost 3,000 deficiencies, 3,000 hospitals that have received a problem not doing it right. So when we decided to start teaching this class, I have another friend who's also a nurse lawyer and another friend who was a very experienced healthcare lawyer. And so we read these like 3 separate times, and we said, is there any way that we could make this a little easier to understand? And we figured out, it took us an all day working on this, that there were about 21 rules. And if you knew these 21 rules, then you would actually figure out what it is that CMS is looking for. And then after this 2-hour webinar, if you go and pick this manual up, it will actually help you to understand what it is that we're talking about. And it will also help if you are going to do a gap analysis. And a gap analysis, and I did one, for example, one time I went as legal counsel, compliance officer, and privacy officer. You wear a lot of hats in a small hospital. So we did the same program that we're doing today, this 2-hour program. We decided who was going to be on a committee, education, chief nursing officer, patient safety, risk manager, whatever. And so what we were going to do is, it's pretty easy to do. So in a gap analysis, we started at tag 154 at the first line. We went through line by line and said, where's this in our policy? Where's this in our auditing? Where's this in our training and our process? And then, there were no surprises. And if you do that, and I have to tell you, as many hospitals, I work with a lot of hospitals that have gotten into trouble with CMS and call me. And in the end, when they say, well, we want to have more training and we want to, make sure our policy is going to stand up to snuff next time. And basically, that's what I do. I literally go through it line by line and say, where's this in your policy? Where's this in your education? It's not in your policy a lot of times. And I was listening to a seminar a few months ago, and there was a speaker, and he said, I don't think you should have your restraint policy more than 1 page. Are you kidding me? I would love to have no more than 1 page, because we know that if you have something in your policy and you don't do it, that you're going to get into trouble and they're going to hold you to your policy. But the problem is, if your policy doesn't reflect what your staff need to know, then how are they going to know that? And if they're not doing it, then you're still going to get cited. So again, that's going to help you. So rule number 1 is that patients have a right to be free from restraint and seclusion. And also, please think about the magical word unnecessary. A lot of times I'll go in and the hospital will say, oh yeah, we have it in our policy, they have a right to be free from unnecessary restraint and seclusion. But you go in, and they're not restraint free, or they'll have 5 people in it, and they meant to say unnecessary restraint and seclusion. And it's only going to be used when necessary to protect the patient's safety or the staff safety. It's not going to be used as coercion, discipline, convenience, or retaliation. And I have done a lot of programs with CMS surveyors, and I was doing one with Renee in Baltimore, Maryland one day, and she said she had just cited a hospital the day before for coercion, discipline, convenience, or retaliation. And it's very bad to spit on someone. That's very undignified, but kind of why we have spit hoods too. But what happened is the patient spit on a physician, so he put him into restraint and seclusion for 2 days, and the surveyor said that was retaliation. And remember that these guidelines from CMS apply to all patients in the hospital, even those in the behavioral health. You may want to consider adding it to your patient rights statement and making sure that you give it to patients in writing. And then this is a restraint chair. I saw this on the internet. So first of all, I have, besides having a law degree and an education degree, I have 3 nursing degrees. And every time I went back and did a semester at the behavioral hospital because I wanted to keep up with, what was new in mental health. And the hospital was very smart. Instead of transporting all of the patients, because we call it pink slipping, or if we made them an involuntary admission, then they had to go before a probate judge. So what they did was they had put the 2 probate courtrooms in the basement so they didn't have to take the patients down to the courthouse. And then they were just saying that this is can be used to do that. It was also, it's gotten some bad press because it was used in a lot of prisons, and they would put these people in them and leave them in them. Like one prisoner was in it for like 48 hours or whatever, and they'd had some deaths. But again, you always, in a hospital, we're always monitoring patients and not just putting somebody in a chair and leaving them there for a couple of days or whatever. On slide 64, rule number 2, and previously CMS did not have a section, for example, like the Joint Commission did, that leadership is responsible for creating a culture that supports the right to be free from restraint and seclusion. Leadership is responsible to make sure that all of our staff are following the rules. So are you auditing it? Are you monitoring the number of restraint episodes? Are you having someone go and review those? Are you monitoring it through the QA/PA process? We'll talk more about that later. Are you making sure that all of your staff comply with that? And previously, CMS did not allow the use of protocols like the Joint Commission used to do, but it doesn't really help us any because the bottom line is if this patient is, say, intubated in the ICU and they're on a propofol drip, when I first put them on the drip, they're so sedated, they're not going to pull out anything. It's not till maybe the next evening when we're lightening up sedation, they don't quite meet the extubation requirement. And then if they go to reach up to pull, at their tube, then I run over, I'll put on a couple of soft wrist restraints, and then I have to call and get the order from the physician. So it really didn't help us any because we still had to call and get the order for that. And so also, and as I mentioned, the decision to use restraints is not from the department because that's how we used to do it. We used to have, for example, the Joint Commission manual was for the hospital, and then they had a separate one for behavioral health, even though the patient was violent, self-destructive in the emergency department. So it's not the department, it's the assessment of the patient and the behavior of the patient. Rule number 3, and this is kind of an important one, is that you need to make sure that you know the definition. And restraint is any manual, method, physical, or mechanical material or equipment that immobilizes or reduces the ability. In other words, if you restrict the movement of the arms, the legs, the body, or the head, then it is a definition. So somebody was asking me, if somebody was spitting on them and they put on a face mask, it doesn't restrict them. It wouldn't actually meet the definition of a physical restraint with what they were using. And again, belts, jackets, cuffs, or ties, and we'll talk about that again. Most hospitals don't use restraint vest anymore. Again, if you manually hold down the patient, that is a restraint. The other thing I wanted to mention is I've worked with a few hospitals. So a patient came in the emergency department and was kind of violent, and so the nurses restrained the patient. The ED physician was kind of backed up, so by the time he got in the room an hour later, the patient had settled down. They were able to remove him, and so the doctor didn't write an order for the restraint. Your physicians, and we'll talk about how they're required to be trained on your policy later on, but the doctor needs to write the order and then DC the order because staff need to be able to use that in your policy and in emergency, and the physicians did not know that. So have in your policy what is a restraint and what is not a restraint, which I'm going to talk about. Now, before we do that, let's talk about when is a drug or a medication a restraint. If it's used to manage the patient's behavior or restrict the patient's movement. Now, the important part is it's not part of the standard treatment and it's not part of the standard dosage. So if a physician orders a medication that is an off-label use, that is 2 or 3 times the dose, that is when it's going to be used as a drug used as a restraint. Say, for example, that I have a patient who has alcohol withdrawal symptoms. He has a substance use disorder problem from alcohol. And the doctor prescribes the normal adult dose of Ativan. that is not a drug used as a restraint. If I look it up in the PDR, I'm going to see that's what it's used for. It's a national standard of practice. It's used to treat a specific condition and enables the patient to get up and join life. So on slide 63, these are 4 points that you should put in your policy that will help your nurses and staff understand when a medication is and is not. Again, look it up in the PDR. Ask the pharmacist, what are the indications? They also have a definition of seclusion, and I used to work in the emergency department, and we had a seclusion room, and I'll show you some standards for the seclusion room later on. But seclusion is not being, we had a 10-bed locked unit. It's not being on a 10-bed locked unit. Now, if you lock the patient in their room or you post a security guard and says, ma'am, you're not leaving this room, then that is seclusion. If somebody's acting out and I say, go down to the quiet room and take a time out, the quiet room is open, the lounge or whatever, they can leave. I might yell at them, but that is not seclusion. Again, being in a locked room or posting a guard saying you're not going to leave, that is seclusion. And this is a document that's actually come out a long time ago in 2003, but CMS still mentions it. And it's meant to help reduce the use of restraint and seclusion in our behavioral health population. And it's been around for a long time. And again, seclusion can only be used if the patient, again, is violent or self-destructive, and the time limits apply, which I'm going to go over. And the 1 hour face-to-face has to be done, which we're going to go over. And I still occasionally get the question about the 1 hour face-to-face is only if a patient is either violent and or self-destructive. A 1 hour face-to-face, so this patient had been sitting, on the behavioral health unit for, 8 hours, and all of a sudden starts throwing chairs and everything and swinging at the staff. Say it's noontime, then they have until 1 o'clock to have someone go in and do the face-to-face, and I'll explain that in just a second. Again, therapeutic holds, if you need to hold down someone who's going to swing at somebody, that is considered to be a restraint, and you do need to have an order for that. And as I mentioned, so we talked about what is a restraint, but what is not a restraint? Remember I mentioned that law enforcement forensic restraints such as handcuffs, shackles, anything like that does not meet the definition and is not subject to these 50 pages. So you need to know that, because sometimes the surveyors don't know that. Now, one time I worked at a hospital and we had a couple of contracts with the prison, so we did see our share of prisoners. So if they came in and they were shackled or had handcuffs or whatever, I would pull out my restraint sheet and I would say, I am monitoring these for patient safety. These are not restraints according to our policy and CMS, to make sure they're not too tight and to make sure there's no problems with that. Also, a restraint is not a double Sean's dressing I just put on the knee, or they have a burn and we put a burn dressing on their leg, or they've had brain surgery and we use a protective helmet for that. Now, they've also made an exception when our patients have had a history of seizures, and we will often, ours were kind of these long green pads with little Velcro, and you had to have all 4 side rails up, and they've created that as an exception. So if you're using the seizure precautions and you have to put up all 4 side rails. And then under tag 161, this is also very important. So one of the hospitals I worked at, when they first came out, CMS came out with 14 hospital-acquired conditions or HACs in which there's no additional payment. What CMS said, if you have a Medicare patient and they get a pressure ulcer, they'll pay for the pneumonia or heart attack, but they're not paying for the pressure ulcer. We're going to eat that. So a lot of our ICU beds, actually all of our ICU beds, they put in those special air mattresses that go up and down. And when they go down, they're very slippery and people could slide right out. So CMS made that an exception. And a lot of times I'll see that as missing in the hospital policy. And then if you hold somebody down for medical reasons, that's an exception. So if I'm going to hold this child, this 3-year-old child, because they're going to have an LP, that is not a restraint. So for medical reasons, that is an exception to the rule. Now, what about um, those narrow carts like in the emergency department in PACU? They're so narrow that if you don't put up the side rail, they can fall out, okay? And we'll talk about side rails in just a second. But if you, like, for example, if I go to the hospital and I say I'm used to sleeping in a queen size bed, can you put up all 4 side rails? And the nurse says yes, and let me show you how to lower those. Okay, so I can self remove the put them down when I want to. They are not a restraint, and your documentation is what is incredibly important for you to document that they can lower them and they're not a restraint. Also, if you have an IV in and you have an IV board and it's not tied down, that is not a restraint. Okay, or again, postural support. So if I go to the operating room and I'm having knee surgery and they have my knee extended, that is not a restraint. Or I go to radiology and they have a knee MRI machine and I put my knee in it, that is not a restraint. And also, if I'm a PACU nurse and the anesthesiologist or CRNA brings a patient in and they're still intubated, that's a continuation of surgery. Mitts. The only time you'll see, we get a lot of questions about mitts, but basically it's covered only in tag 161. So one time we had this patient and she kept scratching her face and she now had a staph infection. And so actually I'm sitting here in Ohio today and it's about 0 degrees with about 8 inches of snow out there. And so, the kids, if they're going out and make a snowman, they'll have mittens on. And so, and again, the 4 fingers can touch the thumb. So we put a pair of what looked like mittens on, and those would not be considered restraints. But most mitts, and I had a lot of conversation with David Ettinger, who was the head of CMS Appendix A for 32 years. He just recently retired, and I miss him terribly. Everything I think I know, I think I learned from him. We used to talk, every couple of weeks. But anyway, he was telling me, oh yeah, sometimes people even put diapers around their hands and inappropriate things. And or if the manufacturer says they're a mitt, then they're governed by this. But so again, the only time you'll see reference. So the question is this a restraint? Okay. So how many of you say yes? Okay. How many of you say no? How many of you say, I don't have enough information? So the correct answer would be the last one. So if this patient can self-remove this and get out and go back to bed or go to the bathroom when he wants, then this is not a restraint. But if this man has Huntington's chorea or amyotrophic lateral sclerosis with muscle weakness and they're not able to remove the Velcro and go back, then it would be a restraint. So the important thing, it's not the thing, it's what the thing does, okay? And I'll show you that in just a second. So if you wrap a child in a sheet and they can't get out like a mummy, that's a restraint. If you tuck the sheet in so tightly they can't move, that's a restraint. Enclosure beds or net beds, if they cannot freely exit the bed when they want to, then it's a restraint. Elbow immobilizers, again, if they can't remove them. Now, one time we had, actually she was fairly young, was in her mid-20s, and she had a central line in, and during the nighttime, in her sleep, she would almost pull it out a couple of times. And she said, I am right-handed. Can you put a restraint on my right hand only? And then in the middle of the night, if I start to do it, it'll wake me up or I'll stop. And then when I go to the bathroom, she could just untie it and go to the bathroom, and then she'd call us and have us put it back on. So is that a restraint? No, because the patient can remove it when the patient wants to. And again, the self-removal part, you would want to document that in your notes because documentation is important. Again, the same way, if I get an order from the physician for some medication, and I go in and I have another nurse with me, and I say, can you roll over? I have a shot to give you, and is it okay if the other nurse is here so you don't jump when I do it? She says, absolutely. That's different than this patient says, you're not giving me that shot, and yes, we are. We have an order, and we have an order to give that shot. So we'll get both of those. We saw that on the forum. So let's talk about, remember we said it's not the thing, it's what the thing does. So let's talk about, we talked about side rails. If I can lower them, it's not a restraint. If I can't, then it is, because my only choice is to crawl over them or to crawl out the end. What about Jerry chairs? If the patient can release the Jerry chair and get out and go back to bed or go to the bathroom when they want, it's not a restraint. If they can't, it is. If it is not, again, documentation is important. So physical therapy comes up to take a patient down to PT, and they take the patient down in a wheelchair, and there's a seat belt, and they put the seat belt on. CMS recognizes that that's permissible. That's a safety thing so the patient doesn't fall out of the wheelchair. Again, important, age specific. So if it's a high chair or crib or whatever, as long as it's age specific, then it's okay. Holding an infant or toddler is not a restraint. And then this is one that you probably ought to share with your security. And I know for years and years and years I've gone round and round with CMS, but for example, one of the hospitals I worked at for 20 years, all of our security were off-duty policemen because they used to work, 12 hours on or 12 hours off. And so basically, so today that policeman might be our security staff, and then tomorrow he might be working as a police officer. So today, if he's working as security, he cannot use pepper spray or mace or tasers or stun guns on our patients. But if tomorrow he is the police and I call them because the patient's being rolly and they place them under arrest or whatever, then they can use that, although we still need to monitor their use. Now, if you have an active shooter in your facility or someone's breaking into the pharmacy, these can be used on, in fact, there's been a lot of rethinking about, arming security. In the past, we armed them with tasers and stun guns and things like that, but with active shooters. But again, if somebody is an active shooter, and then, security could, use any of these devices on them. And then assessment. So, of course, we always do an assessment. So a patient came in a couple hours ago in the emergency department, and all of a sudden she starts getting, swinging and agitated, and I know that she has a history of renal failure. So I call over the lab and I say, hey, is that BUN and creatinine back yet? Or I've had a patient for a couple of days on the medical unit, and all of a sudden the patient starts, swinging and whatever, and I know she's a diabetic, so I'm going to go check an AccuCheck and see if she has low blood sugar. Or that patient was the first time I gave him a dose of an opioid, say Dilaudid or hydromorphone, and now maybe they're having a reaction to the drug. So we've always done that. We've always tried to figure out, what was going on. Is that patient hypoxic? What's going on? Are they getting into a septicemia as to why they're becoming confused and combative? And we've always done that. And of course, we also want to reduce the risk of patients, falling. And as I mentioned earlier, if you automatically, on every patient that falls, automatically put a restraint on 100% of the time, you're at risk for being cited, because there are other things that we can use, low beds and mats and, other types of things. And then, for example, one of the things that kind of is a suggestion is one of the hospitals I worked at, I created a one-page order sheet. So no matter who was ordering it, the physician may not realize that or provider may not realize that they're covering, 50 pages of standards. So it would be on there, and then they could just mark the box. And one of the boxes was the reason for the restraint. Now, later I went back and added an asterisk and said, be specific in the progress notes or the nursing notes. So if somebody is attempting to harm others or property, then I'm going to mark the box. But in my notes, I'm going to say, the patient picked up a chair and threw it at the nurse, or, the patient, was, swinging at the nurse or trying to bite the nurse or whatever. So you want to be very specific about the behavior or the reason for the restraint. So if they demonstrate a lack of understanding to comply with safety directions, it's because they kept climbing over the rail. they kept, whatever it is that they were doing. So again, you want to be specific. And if they pulled out their IV and pulled out their Foley, and I always thought that had to hurt with with the balloon intact, we're going to document that. So have that on a sheet. And again, we had a separate order sheet for patients that are violent and or self-destructive, and also the one that the patient is not violent, not self-destructive. Now, where it talks about here alternatives, we'll get to this in just a second. But when I did the form, I did actually have them on there. We also had a form for the nurse to fill out, and we also had a standard documentation form. But alternatives, it's considered or attempted, not just attempted. So again, we always want to try to do verbal de-escalation. And while Joint Commission added that a few years ago, it's actually not in the CMS standards, but it's something that we always do. We try to talk them down. Distraction, we'll talk about that. And rule number 4 is that you can only be used if you have less restricted interventions. So what could you do other than just tie them up? So patients that have Alzheimer's, they call them sundowner syndrome. Sometimes as it gets later in the evening, they can get worse. And so at midnight, they're up, wandering the hallway or whatever. And so CMS says if they're not harming anything, they're not a danger, then so what? They're sitting in the lounge at midnight or 1 a.m. Maybe they work the night shift or whatever. And then a request from a patient or family member is not sufficient if it's not indicated by the condition. So I had 2 family members one time, and the first one was actually a physician. So I actually showed her the section in the regulation and said, it's not appropriate, but I'm telling you, why don't you and I sit down and draft out a plan of care that you are happy with. And I said, I have all kinds of things in my toolkit. I have low beds. I have, sensors. I have mats that we can put on the floor. And basically, she wanted to stay with her mom because she said the only time she gets confused is at night, and it's only when she's not at home. And I said, I can make that happen. I can, I won't put anybody in the other bed, and you can stay there. And we pushed, her bed up against the wall, and then, we chose things and I said, I can never guarantee she's not going to fall, but I again put together a plan that you're happy with, and in both cases, the patient did well and and the family was very happy. So again, and you want to teach least restrictive. So one time I went to a hospital to work with them, and they had a huge combined medical surgical unit. And they had especially some of the older patients in the late 80s and 90s who had broken hips and things like that. And they would pull out, IVs and stuff. And they had a very high restraint rate. And so we implemented hourly rounding during the day and evening. And that way, when less call lights, and when a call light did go on, they could answer it faster and prevent patients from getting out of bed or whatever. But also they make this sleeve that you can, and there's a little thing that goes over the IV, kind of stuck to the skin, and then a sleeve, and it's not even, and they make them to match the color of the patient's skin. And in fact, I wore one a whole day to see, and I'm like, wow, this is comfortable. Sometimes our patients would ask, can I have one on the other arm, because it kept their arms warm, especially in the winter. But they weren't even considered a restraint. So, looking at a lot of the new products of whatever company that you're using, and every year we used to do that. That was my job, where we would look at any new product and is there a way that we can reduce things. So, for example, so I also got a call from a nurse a few months ago, and she said, Sue, I worked at this hospital for 10 years in the emergency department, and I just recently left. I got married and I moved, and I'm working in another emergency department. And in their emergency department, it's 4-point restraints or none. You can't just put on 2-point restraints. And is that a problem? Yes, it is a problem, because if they're not kicking you, then you only need to put on 2-point soft wrist restraints, not 4-point. So again, you want to try to use least restrictive. Also, you want to try, what are the alternatives that you can do other than, tying somebody up. So when my nephew was 2 years old and was in the hospital, we didn't want to tie down his little arms. So we would have someone stay with them. We used diversion, like, videos and things like that. things that he could work on other than just tie him up. Now, these are some alternatives. We can move them closer to the nurse's station. We can use bed sensors. Again, we can use the skin sleeves I mentioned. There are wedges that you can put under; they won't roll out. We did toileting. Again, low beds. So this is all a list of things, and it's interesting because when I was a junior and senior in high school, I worked full time at the nearby hospital, and I worked on the evening shift. And every night we would put a clean draw sheet on each bed because patients, lay around their bed. It makes them feel better. We would do toileting. We would, give them an HS snack so they wouldn't wake up and be hungry, and that way, there's less of a chance of them getting up, moving around. And we also gave everybody a 3-minute back rub. Again, and then we had one patient who, for example, with our patients that were on blood pressure medication, we, instead of a 9 to 5 schedule, we put them on a 9 to 1 p.m. schedule, so that way they weren't getting up frequently and then, maybe getting a little confused and then having to use, more restraint. My husband likes to listen to classical music every night when he goes to bed. So, if he's ever in a hospital and when he gets older, that would be a good way for him to go to sleep and, again, not get up and worry about that. Caffeine, we had one patient who used to drink a lot of iced tea, and then he was up all night and would get a little confused. And so we limited her caffeine during after a certain time, 6 o'clock, or fluids after 6. So again, she wouldn't get up and march around. So what can you do other than just tying patients up? And the next two slides, I did a program with KeyPro, who is our state QIO a number of years ago. And these are things, alternatives that they suggested, bed or chair alarms, night lights, other things that we could do other than just, tying, everybody up. So one of the things that you might want to have, and I used to have a restraint resource book on all of the inpatient patient care units, and I would have, there was a chapter and it had resources, articles, and things like that. And then rule number 6, you actually have to read with rule number 7, but it's LIPs can write orders for restraints. And remember, that's a licensed independent practitioner. So it's your board of nursing that tells you whether a nurse practitioner is an LIP. It's your state medical board that tells you whether your PA is a dependent or a practitioner. Again, when they do change the terminology, which is most likely to pass this year, to LP, then we won't have to worry. So licensed residents, again, med students cannot write orders. If they write an order, we can't do them until they're signed by the physician. And you do have to specify in your policy who is allowed to write orders so the staff knows. And if you, for example, in the emergency department where I would do 2 or 3 shifts a week, we rarely ever used, the restraints. But one time, again, we had a patient that really needed the soft wrist restraints. And so the medical resident wrote the order, and I said to the resident, did you notify the attending that his patient is in restraint and seclusion? And he said, yes, I did. And you can bet I documented, confirmed with resident that, the attending was notified, and I, wrote their names in it. But I said, would you mind documenting that in the progress note? And he said, yeah. And I said, it's just a CMS requirement. He said, well, thank you for letting me know. I didn't know that. So, I made a special point to talk to the person who does our education of our residents to make sure that they were trained on this. And remember that the resident, the physician should be notified as soon as possible. And Joint Commission used to say, oh, you had 12 hours to notify them. And we really like that, but that'll get you cited. And then they don't say it anymore. But because, again, they had to, they rewrote all of the 10 PC standards when, in 2008, when they no longer had automatic beam status and had to apply for it by CMS. So in July of 2009, they rewrote all their restraint standards. So again, I want to make sure that the attending is notified as soon as possible. And when I read the last 2 years of all the hospitals that have been cited, there have actually been a number of hospitals cited. And I know it's not good. CMS thinks that, 3 o'clock in the morning, that doctor's going to want to know that his patient or her patient's in restraints. I have to disagree with CMS on that point, but it is their requirement. At least the physician can roll over and go back to bed, or the LIP, because of the change. It used to be that if the patient, for example, at 3 o'clock in the morning was violent, self-destructive, then the physician was the only one who had to come and do the 1 hour face-to-face. And now that is no longer true. Now it can be done by an RN that is trained, or a PA, or a nurse practitioner, or a resident, or whoever you train. And when I did the training program, I trained the individuals that are going to do the 1 hour face-to-face on 3 things. First of all, they got the 2 hour program that you're going through today. And by the way, it has been recorded. Second of all, that they had to have, we did a little training course at the hospital, kind of like a CPI training course. Again, there are other companies that are out there doing the same thing, even though CMS mentions them by name in the Federal Register. So that way, if they grab their hair, you go into the lion's den, you can extricate yourself or whatever. And then the third thing was a module program. And we'll talk about this later, but having a form, and I'll show you what has to be documented in the 1 hour face-to-face. And there was just last year, a few months ago, a hospital that got cited because their doctors weren't coming in to do the 1 hour face-to-face. And so they did a big training program to teach all their doctors. And I'm thinking, why would you do that? I mean, the nurse supervisor, the charge nurses, I can train all of these individuals to do the 1 hour face-to-face instead of trying to train, all of my medical staff and having them come in the middle of the night, because they're still not going to do that. You're, I think, fighting an uphill battle. So this was a big thing that when CMS changed this, that we, pleaded with them for years to change that. And then rule number 8, a restraint order was needed. Lots of deficiencies on this. And remember what I mentioned, whatever your for accreditation organization, if you're CIHQ or DNVGL Healthcare, you can actually go online. And please, if you're DND Healthcare, I mentioned that they updated the manual this month in January. And in fact, I mentioned that if the patient is violent, self-destructive, and you have to use, restraint and or seclusion, then you need to get an order immediately and see an order. And they, in the thing in parentheses, they have within a few minutes. So again, we want to be expeditious at getting all that order. And I worked at a teaching hospital, so it was really easy just to call the resident, and all of our residents were licensed physicians, so it made it easy, and then they could just notify the attending if their patient was in restraints. And then there's no PRN orders for restraints, but there are 3 exceptions. And there was a hospital that got cited about 6 months ago because they had a protocol or on a standing order, and then it said if this behavior, then put restraints on. Unfortunately, you can't do that. The only time you can do that is if you have these 3 exceptions. So if you're a behavioral health unit and you have a child who has self-mutilating behavior, in other words, they keep banging their head against the wall, then you can have whenever you can get an order, and then whenever they do that, then you can again restrain them. And then I would pull out my restraint documentation form. The Jerry chair. So the doctor writes an order, or the LIP, that when out of bed, have the patient in a Jerry chair. The fact that the doctor writes that order doesn't tell me if that's a restraint or not. So the bottom line is, if they can't get out, then it's a restraint. And so when I put them in the Jerry chair, I'm going to pull out my restraint documentation form and do that. At least the doctor doesn't have to write an order every time. Or the doctor writes an order, when in bed, have all 4 side rails up. Again, the fact that the doctor writes that doesn't tell me if it's a restraint or not. If they can lower them, again, documentation is important. If they can't, then every time I put them in bed, I'm going to pull out my documentation. That's why many of us will put the side rails up on one side and then we'll have 3 side rails up, and then on the right side, so if they want to get up, they can grab the side rail and swing around and get out of the bed. And then plan of care, again, I was reading quite a few hospitals that got cited for not you have to have a plan of care. CMS says it has to be started soon after the patient is admitted. It has to be in writing. And then when you put a patient in restraints, you have to modify the plan of care. And when you take them out, then again, you're going to modify the plan of care. So again, there needs to be a loop of assessment, intervention, evaluation, and reevaluation. Okay. And debriefing, again, it wasn't mandated by CMS, but and de-escalation, but it is usually required by states, especially in behavioral health units, and is considered to be a standard of care for behavioral health units. And I always felt that was kind of odd. Now, there was a hospital up in Wisconsin that recently got cited for de-escalation because the nurse was talking to the patient in an unprofessional manner. If you don't do this, I'm going to call security, and I'm going to, again, that, instead of saying, oh, I see you're upset, you want to talk about it? I understand. Oh, absolutely. Again, it's the way that we talk to patients. And then end them at the earliest time. They need to be discontinued. And one of the questions that I sent in and got in writing in CMS is when we put a patient in restraint, when I was working on some orders one time, I wanted to write in there that they could, if they were no longer necessary, the nurse could take them off, the RN. And we had criteria for when they could, they're no longer endanger themselves or others, et cetera. And so CMS said, yes, you can have it in there. That way, if it's 3 o'clock in the morning, I don't need to get an order to take them off. I can take them off. And then, but the nurse has to write, restraints DC'd has per restraint order. And then the physician or LP has to then sign off that order. But at least I don't have to call in the middle of the night, and I can take them off. Now, and again, we saw several hospitals that were cited for not ending them when they were no longer necessary. Now, a temporary release is okay. So I'm going to feed them, so I take them off to help them, feed themselves, or I take them off to do range of motion, or I take them off to walk them to the bedside commode or to the bathroom. A trial release is not permitted anymore. It used to be allowed in the old days. And a trial release was, okay, I got an order for 4 hours, and the bottom line is it's only been 1 hour, and the patient says, and I would always tell the patient, now, if you do this, we can take these off. If you quit trying to bite the nurse or kick us, then we can take these, restraints off. And so if I'm wrong, the patient says, I'm sorry, I don't know what I was thinking, I won't do it again, and I take them off, and I'm wrong, and the patient says, ha, fooled you, and then starts kicking and trying to bite me again, then I have to put them on, then I have to call and get a new order and start from the very beginning. So a trial release is not permitted anymore. And I was recently at a hospital, and I was looking at their policy, and they still had that in there. And again, the policy should describe the circumstances when they are being able to be discontinued and who is allowed to take them off. So the nurse would make the decision. In the hospital where I worked at, the nurse aide, if I said go ahead and take them off, they were trained to put them on and then to take them off and to help monitor the patient. And rule number 11. So we talked about assessing, and again, if all of a sudden this patient goes berserk, we go back and try to figure out what changed. Was this a medication? Are they hypoxic? Are they going into septicemia? Is it because they're renal failure? They're in renal failure or whatever. But CMS also took out the word continuous. It used to say we had to continually monitor patients. Well, the only time we need to continually monitor patients are patients. And we'll get to that. It's rule number 20. If they are violent and or self-destructive, and they are in restraint and seclusion. Other than that, for example, our behavioral health patients, we make 15-minute rounds, and we assess them every 15 minutes. But our medical surgical patients, it could be 2 hours, or 3 hours, or 4 hours, whatever it is that you select. Now, many of you and most of the hospitals I go in, they still have every 2 hours. So first of all, if you select every 2 hours, please say at approximately 2-hour intervals, because if you were in there at 4 o'clock and you don't get in there till 6:15, you have violated your internal policy. But if you say at approximately 2-hour intervals, and so I know if I've got a nurse working a 12-hour shift, I'm going to expect 6 assessments. You can do that. Also, you don't have to pick the 2-hour time frame. So I have a friend who is a pediatric nurse who works on in a pediatric hospital with children that have cleft lip surgery, and they don't want the child to reach up and rip out their sutures. They have every 4 hours, and there was one hospital that had been cited a bunch of times because their staff couldn't make the 2-hour assessments. So again, if you want to change it to 3 hours or 4 hours, so this is what CMS is talking about, and I know the Joint Commission was not happy with CMS and wanted them to change it, but they did not. In fact, CMS said, it seems to me that every 2 hours is not good, especially during the night when we understand the importance of REM sleep. Now, we used to go in with, flashlights and check them to make sure they weren't too tight and that the fingers were pink and warm and things like that. And again, they don't tell us the time frame. Rule number 12 is the importance of documentation, and I can't say enough about that. So whenever I had a patient on the medical surgical unit, wherever I was at, that we put restraints on, I automatically put them on I&O because they can't just reach over and, grab water. If I'm thirsty, I just reached my glass and I took a glass, drink of water. They can't do that. And I don't want their bladders to get distended because they can't just get up and go to the bathroom, when they want. Now, we did put their call light so they could, press their button. But again, if they're confused and they can't do that, vital signs, going to make sure that they're not too tight, that they're cutting off their circulation or they're having an abrasion with the skin integrity. So documentation is a big component to monitoring our patients. And in fact, I was talking about earlier the restraint chair that prisons started using, and they never checked their patients. They just would put these prisoners in these restraint chairs and just leave them. And you can't do that. You can't do that with any type of restraint. Again, you want to document the specific behavior. Remember, we had reasons to restrain that we checked, but we want to talk about, exactly what the patient did. Again, what were the symptoms and conditions that warranted the restraint? So we want to be very, very specific. So one of the questions that somebody called and asked if I would address was, if they have 4-point restraints and they no longer need 4-point, they only need 2-point, do you need to get a new order? And the answer is yes. Now, remember I mentioned that if you have in your orders that when they can be DC'd, that you can then do that as the protocol, then write the order, and then the doctor can sign it off. Again, if you're using elbow immobilizers and they have 2 on, now if they just have 1 on and they can take it off when they want self-removal, then it's not a restraint. And then we talked about hand mitts, when it is and when it is not. And again, most of those are restraints unless they're really like the mittens and they're not bulky and they can kind of. Now, if it's a real hand mitt, like I was mentioning, they can bend their forefingers to touch their thumb. They can still pull out the NG tube, the Foley, and other things. Again, most hospitals aren't using a vest restraint. Papoose board. Now, when they made a change a few years ago, if I'm suturing a child in the emergency department and they're on a papoose board, that is not a restraint. If you've got a kid acting out and you strap them down on a papoose board, that would be a restraint. So again, if you're using a papoose board to suture children, then that is not a restraint. Remember we said, and also if it's for medical reasons, you're holding them, that is not a restraint. So this is not a good documentation sheet. So one time I was going to a hospital for 2 days, and the first day they wanted me to look through charts and get some actual examples and recommendations on how to improve charting. And then the second day we were having an all-day program on improving documentation. And so I'd come in at 7 a.m. And so I was looking at the restraint flow sheet from the night shift. And so basically, somebody just had marked every one of these boxes. So under circulation check, and first of all, at the top, it didn't say the exact time and that they were in there. So again, if they were in there at 2:15, it needs to be 2:15. But for example, circulation check was what were they checking? Were they checking pedal pulses or capillary refill, or were they checking to see that the fingers were pink and warm? Elimination, BR, I think stands for bathroom. I said, did you really get this patient up every 2 hours and take him to the bathroom? No, we didn't do that. Well, you had the box marked. And when we had patients that were in restraint, we would always document again, every 2 hours when we would offer them fluids, we would say drank 40 cc's, and we kept track of that. And the same thing with bathroom, up to bedside commode, voided 240 cc's or BM times 1 or whatever. Passive range of motion. Did you really wake them up and do passive range of motion in the middle of the night? Of course they didn't. Trial release, remember we said there's no such thing. Assess for early release. They had criteria and that's a good thing to do. But again, this is not a very good documentation sheet. So again, having a record where we can get everything we need. And then you want to do QAPI. Again, somebody measuring the number of restraint episodes or someone looking at the charts to make sure that they're being done correctly. And I used to do QAPI because we want to make sure we're not using more on the weekends or more with agency nurses or any one specific person. So one time I managed, and this was back in the late 80s, several departments of a hospital, and I only had one nurse, and she seemed to be the only one to use those. So again, we did an intervention with training so that she wouldn't do that. And then rule number 13 is use them as directed. So when we were using the restraint vest, if I would go around the hospital, and half the time they'd be crossed in the front and tied to the bed frame, the other time they'd be crossed in the back. So again, if you look at the manufacturer's recommendation, they crossed in the front. Or again, if they're putting on a soft wrist restraint, and this is the difference between education and competency. So every year during skills lab, whatever restraints we had on our list that staff were likely to use, they would demonstrate, put it on, and show me. So they would put on a wrist restraint. And again, we want to make sure they have, the slip knot appropriate to there. And then if the patient gets injured by a restraint, then again, we would fill out and get it into the incident reporting system. And rule number 14 was kind of the lightning rod for activity. And the bottom line is if the patient was violent and or self-destructive, that's the only time you have to do the 1 hour face-to-face. But so if that happened at noon, we have until 1 o'clock to get that person there at the bedside to do that. And as I mentioned, it used to only be allowed to be done by a physician. And this was really not a safe practice. And I can't tell you how many times I wrote CMS letters and sent them emails. So if my surgeon has to come in at 3 a.m. and then gets back home and has an hour's sleep to come back and do surgery all day, that is not, safe thing when it's really not necessary. So the big change was that again, whoever you want to train, RNs, nurse supervisors, charge nurses, PAs, nurse practitioners, and it is clear that a PA can do the 1 hour assessment, even if they're dependent practitioners in all states, as long as the hospital allows that. So again, that was the big requirement. And I mentioned there were 3 things that we trained on if you were going to do the 1 hour face-to-face. And again, the whole point is to figure out, what's causing it? Is it really necessary? Now, slide 117 and 118 are important because this is what you need to document on the form. And you should have a form, so no matter who's doing the 1 hour face-to-face, that way you're going to make sure that all the information that you gets on there. So the reaction to the intervention, so if I go in, are they sleeping? Are they agitated? What's the medical and behavioral condition, which we'll talk about on the next slide? And at the end, is there a recommendation to continue or remove restraint or seclusion? And if you have a H&P on the chart, it's going to make it easier. But what they're wanting us to do is do a review of the system. So basically, is this a patient who came in for schizophrenia, or is this a patient who came in for renal failure or for uncontrolled diabetes? And then again, they want us to look at, was this a recent medication? This is a first-time opioid that I gave this patient who's never had one. I gave her Dilaudid or hydromorphone. So is she having a reaction to the medication? Or again, is there a lab test that's out of whack? Sugar is 972, or the BUN creatinine is sky high, or whatever. And again, we want to see if they're getting hypoxic, or if there's an electrolyte imbalance. Are they getting septic? And then we want to write this in the plan of care. And again, you need to train your staff. Remember, I said we trained them. They got the 2-hour program that you're getting today. And then we had a module, computerized module program that walked us through the form and how to create that. And then we did a trainer program, like something like a CPI, train the trainer program that they would go through every year. And if they are violent and or self-destructive, then I get an order. We have the face-to-face. And normally what we would do is, instead of having the nurse call the physician and bug them twice, if they were violent and self-destructive, we would call the person to do the 1-hour face-to-face, and then they could call the physician. That way they can get the order, they can provide the physician all the information that they need, and not have to interrupt them twice. So if this is, and there are a lot of hospitals that got into trouble because they weren't calling every 4 hours and getting the order. That was another common thing that we found when we looked at all the deficiencies on why hospitals are getting into trouble. So not having an order, and then if they get an order, then this is an adult, and every 4 hours I can call the doctor or the LIP and renew that order up until 24 hours. And at 24 hours, I have to have the physician or an LIP do a face-to-face. If it's children, it's 2 hours, and if they're under the age, it's every hour. And that is the same for all 4, the Joint Commission, and actually all 4 accreditation organizations. Now, I mentioned that if they're violent and or self-destructive, that the order is every 24 hours, not daily, not 48 hours, every 24 hours. If they are not violent, not self-destructive, then you renew the order in accordance with your policy under tag 173. So the bottom line is, it could be daily, it could be 24 if you want, it could be 48. So I've been at a couple of hospitals, and I asked them what their renewal order time was, and they said, well, we thought it was too confusing for staff to remember 24 hours if they were violent, self-destructive, and 48 hours if they were not. And so we went for 24 hours. So when we audited the chart, we found 5 patients whose orders who were nonviolent, who they could have picked 48 hours, but they didn't, and now they were violating their own policy, which was higher than what was necessary. So again, if once they switched to 48 hours, then they were in compliance 100%. And then you need a policy on restraint and seclusion, and everything we've talked about has to be in there. So remember I mentioned the gap analysis, where if you can have, we did as a committee, and we literally went through it line by line. We started at tag 154, and we went through it line by line and said, where's this in our policy? Where's this in our training? Where's this in our process? To make sure that we hadn't forgotten anything. And then education, there are 10 pages of educational requirements. So one, you may want to consider having a list, and that's what we did. We had 1 page, and we listed all of the things that were in here, and then we covered them. And it says on an ongoing basis. I don't know what the heck ongoing means. So I called David Ettinger, who for 32 years was, at least I think he's there 32 years. He just retired. And he said, we expect it to be done on an annual basis. I said, well, David, why didn't you just use the word annual? Because I know what annual means. I don't know what the word ongoing. So you should be doing this, once a year. And what you do is anyone who's going to put them on, take them off, or monitor them has to be trained to make sure they can do it correctly. Don't forget about your radiology techs. If they take them off a cart or bed and put them on a table and then take them off, or your ultrasound tech. So we made a list of anyone our nurse aides could put them in, take them off, and monitor them. Of course, the nurse would, on the nurse's order, again, physician would order, the nurse could say, go back and put these on. And so again, you want to make sure that everyone is educated. And remember, education is what we're doing today. Competency is when I watch you put on that soft wrist restraint and document that. So again, patients have a right to have them have safe implantation. Patients have a right to have these put on by trained staff. And again, so if you're putting them on or monitoring or providing care, you need to be trained in whatever it is that you're going to do, and you need to be trained before you're assigned that patient. So my niece lived with me for 4 years when she went to nursing school, and then she went to a hospital that had a 9-week orientation program, and they would spend half a day in the classroom and then half a day in the afternoon on the unit. So you would want to move that up and make it early in their education, so that because again, she can't monitor or can't do anything with the restraint if she's not had that training first. And again, consider doing it. For example, most hospitals have skills lab and do that. The education and competency is the same with Joint Commission. And as I mentioned, CMS doesn't say anything about de-escalation. A few years back, actually, it's been 2013, because we had all the patients that were boarded, psych boarding in the emergency department. And so they came out with, the Joint Commission came out with PCO 10101, EP4 and 24. But again, we have had cases where if you weren't doing de-escalation, it's the way, there was one nurse I used to work with, and he was a very good nurse, but he was not the nicest person and not probably someone you'd want to put out at triage. And one time I thought this man was going to hit him. I went out to relieve him, and he's like, "Sir, you stepped into my area. I'm with a patient, and if you don't leave, I'm going to call security and whatever." Again, that's just not the way you want to approach patients in a calm manner. Avoid confrontation. It's the way you talk to people. You sound like you're angry. Would you like to talk about it, as opposed to, being angry. And this is personal de-escalation plan. So, sometimes people will say, "Oh, it triggers me if someone yells at me." When I was a little kid, I never liked being yelled at. Or loud noises. We actually found, and you're supposed to be trained in triggers also, but we found one time that there was a patient, who had a little bit of Alzheimer's, and her roommate was really hard of hearing. Whenever she would turn the TV on, she would turn it off really loud so she could hear it, and the other patient would just get agitated and whatever. And then we realized what the trigger was, and we moved her to her own room, and it never happened again. Again, you want to make sure that you put them on safely, training how to recognize and respond to signs of physical or psychological distress. Again, we don't use vest restraints very often, so it was positional asphyxia that we were, worried about. And again, you want to train your staff. So when are they no longer necessary? When can I take them off? And again, if they are in restraint and or seclusion or both, then we want to know how to assess them, vital signs, and that they're not too tight, and all the things that we talked about. And when they talk about first aid technique, CMS is not talking about taking an 8-hour first aid class. What they're talking about is if I walk in and they've got it wrapped around their neck, or they pull, I'm gonna extricate them. If they're not breathing, I'll call a code and start CPR. So just have a few examples. They pulled out their IV, and I don't want them to exsanguinate, so I stop the bleeding and put in a new. So just develop some scenarios. Again, make sure you're documenting training and competency, where you observe them, whatever you're using, you observe them, put them on. And again, since a lot of times when we got a problem, security stat to the emergency department, we've got someone who's ballistic, and they're often the ones. And it's really important to do that. If you've been reading the papers the last couple of years, security guards, again, CMS suggested that you give them an 8-hour CPI training course. Again, there are other companies that are doing this. I think they just mentioned them by name because they've been around for a long time. But you really do want to make sure that your security guards are doing it correctly, because they have created and been involved in a lot of the cases that have gotten hospitals into trouble. And we'll talk about the emergency department physicians. We've seen quite a few recent cases also where they weren't trained in the policy and didn't know what the practice was. So as far as training, CMS does not require you to do so many hours of training a year. They do have a recommendation, though, and the recommendation shocked a lot of hospitals. So 7 to 16 hours. Now, our behavioral health nurses used to get 8 hours a year, but in one hospital I worked at, it used to be, a 1-hour program, and we increased that. But again, if I've got a group of people and they've been there a long time and every year is just refreshing, or I walk in and all of a sudden there's a lot of turnover, there's a lot of things that can mandate, what departments you're going to do. And also, CMS requires you to have one person who's going to revise your training program every year, and they estimate that it would take about 4 hours every year. Well, this was my responsibility at a hospital. And by the way, I still find a lot of hospitals that aren't doing this, and I'm surprised there aren't more hospitals cited because this is a requirement. But I would do a literature search. In orientation, I had some questions, and they had to answer the restraint questions, and they would tell me, what percentage of people got it right. And then in our patient safety walkabout, I had several questions in there, and they'd say, okay, we asked this question 100 times. And I would ask, do you know where the restraint and seclusion policy is? Or I would ask some questions that were basic things in the policy. And if they got it right, they actually got a ticket, and they could put it in for a free drawing for a couple of $100 gift certificates at the local grocery. If they got it wrong, no harm, no foul, but they kept track of it. So I could tell, where are people doing that? And again, I would look at our vendor and determine, are there any new products that are on there? I would have our librarian do a literature search to see, is there any literature out there, anything new? And it would take me about 20 hours a month, but you are required to have one person. And then all of your physicians, at a minimum, must be trained in your hospital policy. So every 2 years when we would recredential and privilege, I would say CMS requires all physicians and LIPs that write orders for restraints have to be trained in the policy. Here attaches the policy, and you're going to sign an attestation that you've read it and that you understand it. And as I mentioned, I had all kinds of other resources. I had a videotape that I wrote that accompanied. We actually filmed it at our hospital on Restraint and Seclusion. That was a good way to get people interested because all the people were, people that worked at the hospital. We didn't use any real patients in the filming of that video. I had a CD. I had a self-assessment learning guide. I created a lot of other resources, and any of the physician groups could call me and let me know. And then remember, we mentioned that a state can have a stricter one, and sometimes if you have a separate behavioral health unit, they will have a stricter one. And then remember, I mentioned that if you have someone who is in restraint and seclusion, both, then there has to be the face in the window, or if you're lucky enough to have audio and video recording close by where we're monitoring those patients. And again, every 15 minutes is considered to be the standard where they would, they're documenting that they are on a one-to-one. And by the way, a one-to-one means a one-to-one, meaning you one staff or one nurse. You can't have. Recently, I was at a facility, and they had a policy on one-to-one, and they had 2 rooms, and they had the person sitting in the hallway at a bedside table documenting watching 2 patients. That is a 1-to-2, not a 1-to-1. And then we already talked about reporting death. But if the patient gets a restraint that causes a death, maybe they get it wrapped around their head and they die, there's also another federal law known as the Safe Medical Devices Act that you have to report. And if this would happen, for example, since we know that 90% of the hospitals are accredited by the Joint Commission, that if they die, then you have 45 days to do a thorough and credible root cause analysis. And then I already talked about when you have to report not to the State Department of Health or the state agency, but to the regional office. And I gave you an email on how you can find out who your regional office is. So I'm in Ohio. My regional office is in Chicago. and I gave you the email that, or the website that will give you the address, phone number, and everything if you have questions. And again, you have to fill that form out. And again, the exception is if they just die in one or two soft wrist restraints and doesn't cause their death, then you only have to do an internal log, and you're going to document in the chart that the internal log was completed as required by CMS. And when I go in and I ask about internal log, who keeps it? Is it electronic? Who monitors it? A lot of people look at me like they have no idea what I'm talking about. So don't forget to do that. So again, if they have 4-point restraints or hard restraints, again, you're not supposed to be using leather restraints because we can't clean them unless they're fax leather. So if they had 4-point restraints on and they died in a restraint within 24 hours, even if the restraint did not cause a death, or within 7 days and the restraint caused the death, you need to fill that form out. I showed you how to fill the form out with it. And then if it's only the 1 or 2 soft restraints, it's tag 214. And the internal log has to be done as soon as possible and never more than 7 days. And in the internal log would be the patient's name, date of birth, date of death, attending, medical record number, and primary diagnosis. This is what it looks like. So in conclusion, you want to make sure that anyone who puts them on is familiar with that. You always want to make sure that, again, our boards are responsible, that they're always educated and leadership is aware of their responsibilities. Again, our staff should be trained on what it is they're supposed to do. On the state law, on the CMS, 50 pages of requirements. And on your accreditation organization, your policies should reflect what are the standards. And again, auditing that to make sure that you're doing this correctly and having someone do that. This is, by the way, just a lot of what we learned about restraint and seclusion that we learned from long-term care. And then this is something that CMS puts out that is kind of a worksheet for that. It's helpful. And then this is a recent article that came out on alarm-free environment guidelines for safe, smooth transitions. Basically, we still use a lot of alarms in the hospital, but if they can alarm like in the nurses at the nurses station or whatever, especially in long-term care, if the alarms were so loud and were so oversensitive, and every time the patient moved, then in long-term care they were considering them to be a restraint. So we definitely want to make sure they're not so sensitive that every time the patient moves they're going to go off and they feel like they're a prisoner in their bed. And then CMS also says that you need to follow the standards of care and standards of practice. And for example, the American Psychiatric Nurses Association does have a standard of practice on restraint and seclusion. And also, there is a guide. They just updated it actually 11 months ago in February 2018, especially because we house a lot of behavioral health patients in the emergency department with the bed shortage and whatever. But this is how to create safe rooms. And it's also in light of one of the 4 top issues of Joint Commission is preventing ligature risk and preventing patients from committing suicide. And of course, CMS came out with Tag 144 and 701 in their 13-page memo. So again, we want to keep them safe and creating safe rooms. And there's 3 documents. They're all free. The VA has one. This is one by David Stein. I'm going to show you they have a new name last year, Behavioral Health Design Guide. In other words, how to create safe or safer rooms. And if you're a behavioral health unit or behavioral health hospital, they have to be ligature resistant. In the emergency department, we have one-to-ones, and we do other things to keep our patients safe. And it also has a self-assessment. But this is also how to design seclusion rooms and whatever. Again, it's a free, and that's a different lecture that we do. And that brings us down to the end. And we wanted to save some time for questions. Now, you don't have to. It's a 2-hour program, and if it goes over, I've told them I'm happy to stay on since we did have 570 hospitals that had signed up, for the program, that I'd be happy to stay over a little bit if we had questions. But remember, I always give you my phone number, and you can call me even if it's in a month or 2 months. Again, I don't accept emails because sometimes I don't get them or I don't understand them. And as I mentioned, my office hours are from 10 a.m. to 10 p.m. Monday through Thursday, so you have lots of time when you can call me. And usually I'm done lecturing and teaching by 5:30. So if you call me in the evening, you almost always find me working at my desk. And please, whatever you do, don't call me at 7 a.m. and wake up my family. They're always sure that somebody has died or something terrible has happened. So at this point in time, I'm going to turn it back to Katie, who is our moderator for today. And Katie will tell you again how you can ask a question if you would like to ask a question. And again, if you look on the right-hand side under handouts, there is a copy of today's PowerPoint presentations that you can download. So Katie, back to you.
Great, thank you so much, Sue. And we've had some questions that have come in throughout the presentation, so we'll get to just a few of them right now before we close up. So the first question we had come in was, for the nonviolent patient, is the face-to-face by the LP within 1 hour of initiating restraints required?
Okay, so first of all, a face-to-face only has to be done on patients that are violent and or self-destructive. So if this patient is throwing chairs and trying to bite the nurse and kicking the nurse, and they're considered to be violent and or self-destructive, that is the only time that you have to do a 1 hour face-to-face. So if it is, say it's 1 o'clock in the afternoon, then you would have until 1400 or 2 o'clock in the afternoon to have that person get there at the bedside of the patient who's violent and self-destructive and do the face-to-face. It no longer has to be the physician unless your policy says that. So I mentioned that there was a hospital that just recently got into trouble and trained all their doctors on doing the 1 hour face-to-face when they don't have to do the 1 hour face-to-face. You can train a nurse, a nursing supervisor, a charge nurse, a PA, a nurse practitioner. It doesn't have to be done by the physician. But again, the 1 hour face-to-face is only on patients that are violent and self-destructive.
All right, thank you. The second question we have, are CAH hospitals to be compliant with Appendix A or just Appendix W?
So if you are a critical access hospital, you have to follow Appendix W. If you are a critical access hospital and you have a 10-bed behavioral health unit or a 10-bed psych unit, which you're allowed to have, you must comply with Appendix A. Critical access hospitals follow their own manual. However, we have seen some critical access hospitals being cited because you can't just not have any policy on restraint and seclusion because you still have to follow standards of care and standards of practice. And as of 2 months ago, when I looked at the data, we have 1,313 critical access hospitals in the United States. And so you have to do something. So a recommendation is, because you still don't want to have a wrongful death, you still don't want to, be sued or whatever when patients get injured. And CMS in the Critical Access Hospital Manual on April the 7th of 2015, they rewrote 93 pages of the Critical Access Hospital Manual, and they talk about safety and things. So you still have to do something. So our recommendation, other than the reporting requirements, is that when I've worked with critical access hospital, we pretty much adopted the same thing.
Awesome, thank you. And before we go to the next question, for anyone who has to hop off the presentation at the top of the hour, I just wanted to give a quick reminder that the slides can be accessed in the handout section of this webinar, and a recording of the presentation will be made available as well. And then as another reminder, if you've joined the presentation with a group of your associates and only one person is registered, please email their first and last names and their email addresses to cmalooly@tidyproducts.com. That's C as in cat, M as in Mary, ALOOLY @tidyproducts.com. Each person will receive a webinar survey where the option to receive the credit is available, and you will receive the certificate 1 week after completing the survey. Okay, so for anyone who can stay on for a few more minutes, we'll just go through a few more questions. This one is, in reference, actually, I'm sorry. So this individual is in the state of Ohio and asked, just to clarify, were you saying that physician assistants are not able to write restraint and seclusion orders?
Yeah. So the person that's in Ohio, basically, what CMS says is that a physician or an LIP, licensed independent practitioner, can write restraint orders. The Ohio State Medical Board, like several other medical boards, have determined that in our state, PAs are dependent practitioners. So the problem is that you're at risk if you allow a PA to write an order. Now, that should shortly be remedied when they pass this new federal law. So to be clear, that is a problem. Now, they can do the 1 hour face-to-face. Right now, there's no question that they can do that. But the problem is, if you want to do a technical reading of CMS, that could get you cited if a surveyor was aware of that. So that is why we need to change. And CMS said, yeah, we don't really have any problem with PAs writing orders. And in fact, when we changed the definition from LIP to LP, so I think what happens when I looked at the data recently, ever since they've announced this, I think a surveyor is less likely to cite you even if they find it because they know that it's going to change and that CMS wants to change it. So I think sometimes I've just seen surveyors, it's not worth citing you, it's not a big deal. But technically, until they change it, you are fair game for being cited.
All right, thank you. And I think we'll do two more questions. This one is states, we do not have any protocols for typical restraint needs scenarios, such as with intubated patients. With the removal of protocol restrictions, any advice on appropriate wording, such as for intubated patients, may have soft wrist restraints, which may be applied, order documented per protocol, and then if a restraint order renewal is needed, a new order will be written for each renewal situation.
Well, the problem is that that's probably going to get you into some trouble because we love the way the Joint Commission used to do it. And in fact, when I worked in an ICU, we used to automatically, any intubated patient, we would automatically put them on right away. But, when they're so sedated, like, they're on a propofol or Deprivan drip, they're not going to pull on anything. So if I'm trying to, to get them off the ventilator, but they don't quite meet the extubation requirement and they reach up and try to start pulling it out, then I have in the policy the emergency provision that says I can go and get them, but I still have to get an order. And so we saw some hospitals that tried to have protocols to say that you could put them on without getting an order, and they've all been cited. So again, even though they said, oh yeah, you can have protocols and all this, the bottom line is it doesn't help me if I have to call and get an order, when I have to use them for that patient. But you have in your policy the emergency part of that if they go to, reach for those. And again, we hope that they, we can, again, apply them and then go and get the order. So it didn't really help us any.
All right, thank you. And the final question that we'll be able to get to today, are having rails up for a dementia patient who can't lower them considered a restraint? And do you need to follow restraint procedure the entire time they are in bed?
Yeah, so if I have a dementia patient and I put up all 4 side rails and they cannot lower those are a restraint. And I need an order from the physician that says when in bed, have all 4 side rails up. That way, whenever I put them back to bed, I'm going to pull out my restraint documentation sheet and I'm going to document, whatever you're using, 2 hours, 3 hours, 4 hours, whatever you're using, and then I'm going to, fill out my form. So if they cannot remove the side rails and all their choices to go over them or at the end, then they are considered to be a restraint by definition of CMS.
Wonderful. Thank you so much. So, Sue, thank you again so much for your time today. We really, really appreciate it. And thank you to everyone who participated. If your questions were not answered, you can see Sue's contact information is on that final slide. So feel free to reach out to her. Again, thank you all so much and have a great day.